I'm happy to present Dr. Tracy Downs, who is a professor of urology at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin. He is also a board-certified urologist specializing in the surgical treatment of urologic cancers. He received his medical degree from the University of California, San Diego School of Medicine, followed by his urologic surgery residency at Harvard and a 2-year urologic oncology fellowship at the University of California, San Francisco. Dr. Downs is also the Associate Dean of Diversity and Multicultural Affairs at the University of Wisconsin School of Medicine and Public Health. He plays an instrumental role overseeing the recruitment and support program for students who are from racial, ethnic, diverse backgrounds, underrepresented in medicine during their medical school years. And from 2016 to 2020, he served as the director of the Centennial Scholars Program, an institutionally funded program to support the career development of underrepresented people in medicine. At the heart of his diversity work, Dr. Downs realizes the importance of building a more diverse healthcare workforce. And today, Dr. Downs will be presenting Mind the Gap, Origins of Health Disparities and Why Zipcode and Race Remain Structural Barriers to a Healthier America. So Dr. Downs, we're looking forward to hearing your talk, and you could share your slides if you're ready.
So really excited to be here with you all, and honored for the invitation. I'd like to thank Dr. Kinney for the invitation. I think I speak on the behalf of many individuals around the country of how much we admire and respect the major contributions to the field of urology that Yale Urology is indeed making and continues to make. I also want to just shout out to a couple individuals who I know, I consider good friends. I hope they think the same. So one would be Dr. Dinesh Singh. We were residents together, and I've always admired him on many levels. And then Dr. Adam Hiddleman, who we go back and we love to talk about when he was interviewing, and then I swapped over to UCSF when he was a resident. I was a fellow, and he gives me constant grief on that. But I've been admiring your career from afar, and it's just been neat to see you're the same curious, dedicated person you were when you were interviewing, which shows you my age. And then I know Dr. Coleman from different committees and societies that we've been on. And I also want to make sure that I thank Sheila for coordinating all of this, as it's always a heavy lift. So we'll kind of roll into it. So one thing here for those of you who may be, as I am, was challenged by knowing the US geography. And so I grew up in California, trained in New England, and so I knew the coast well. And they actually have a term in the Midwest for people who are from the coast. They call them coasties. And so I actually didn't know that there was a body of water here in Madison, and we've got these beautiful lakes, and the university you see here is actually on the isthmus, and there's another lake over there. So it's just a beautiful part of the country. So this will be the talk, and I'll try to kind of stitch this together with the themes that I think will underpin not only what we do full-time is trying to reduce health disparities, but looking at it from a scholarship perspective, but also reducing it down to the basics of just where someone originates from based on their zip code, and how these are structural barriers to a healthier America, and then tie it in with some things that I think are pertinent to today. I have to be honest, knowing that this talk was coming after the election, I was very interested to see how that would impact the talk, and also to acknowledge that in any crowd, there are people that are have different views, and that's good. That's one thing I think that we value about America. And so hopefully I come across as someone who embraces open dialogue and just really sharing, I guess, how I see things. So, so this is a slide from David Williams, who came out at a health equity conference we had about 4 years ago. And when we looked at data from 2014, and we look at life expectancy in the US, we're not very good. We're 34th out of all countries. Japan is the first, Italy is the second. And when we break down the US between white citizens, we'd be 34th. And when we look at Black citizens only, we are at 96. A quick greetings from our department here in Madison, and there may be some familiar faces that you see here. These are our residents, our advanced practice providers, our NPs, our PAs, as well as our residents and faculty and our administrators. And then, of course, greetings from my chairman to your department, Dr. Steve Nakata. And again, there may be some faces and individuals that you guys recognize. So I want to share with you first something that we hold near and dear to our heart here in Wisconsin, and it's called the Wisconsin Idea. And I want to tie that in with the quote that John F. Kennedy said, that a man may die, nations may rise and fall, but an idea lives on. Ideas have endurance without death. And so that idea, the Wisconsin Idea, really was originated by President Charles Van Hise back in 1905, and he declared, "I shall never be content until the beneficent influence of the university reaches every family of the state." And it's really something that galvanizes us here in Wisconsin when we think about strategic planning, when we think about being aspirational, when we think about mission and vision statements, pretty much across most schools, departments, units, etc. Everyone kind of comes back to this. And it really embodies that our education should influence people's lives beyond the boundaries of the classroom. And we actually believe it should not only touch every corner of the state, but actually even beyond. And so here at the School of Medicine and Public Health, our mission statement is this: advancing health without compromise through science, through scholarship, through service, and through social responsibility. And we see our dean at the top photo here, Dean Robert Golden. So health disparities, and I think before assuming that they exist, a good question would be, do they exist? You just heard us talk about our aspirations here in Wisconsin and how we feel, very, inspired to touch every corner of our state. This is data from the Agency for Health Research. And when they analyze across the globe, and here is Wisconsin, we came out as having, being in the top quartile for health relative when we didn't break down the demographics of our citizenship. So when we looked at all citizens, we were in the best quartile for health. When we looked at individuals who were Black, Hispanic, or Asian Americans, what we found out is now we were actually in the lowest quartile. We were the fourth. So Wisconsin ranked in the worst category for quality of care when you broke down things based on different ethnic groups. So the definition of health equity means that everyone has a fair and just opportunity to be healthy. This requires removing obstacles to health such as poverty, discrimination, the consequences, including powerlessness, a lack of access to good jobs, fair play, quality education, housing, safe environments, and quality healthcare. So back in 2004, US Senator John Edwards from North Carolina gave a speech that led into a very catchy phrase. He coined the term, "There are two Americas," in which there are the haves and the have-nots. And so when we think about sustainable health, we have, and we talk about it all the time in our healthcare environments about wellness, but the opposite direction is illness. And really for communities, for individuals, for us at work, we really need all of these things going and pulling in the same direction, from environmental factors to economic factors to social factors, leading to us being able to sustain health. As a School of Medicine and Public Health, we consistently talk about the health factors or social determinants of health that contribute to healthy outcomes. And what this slide is depicting is that 80% of health outcomes is not determined by the clinical care that we provide. Those are by healthy behaviors that individuals do or do not. 30% is contributed by that. Then there's social and economic factors such as your education, where you work, your income, your family support, and your community safety, which contribute to 40%. And then the physical environment adds 10%. So one project that we've embarked upon here in Madison at UW is tied in with the neighborhood atlas, and this will link to the zip code analysis. And what we know historically is that poor and minority populations often live in socioeconomic disadvantaged neighborhoods, and this directly affects their health. And so to make neighborhood disadvantage metrics more accessible to key stakeholders like policymakers, researchers like yourselves, our patients, care providers, caregivers, and clinicians, they brought together an American Community Survey Derived Area Deprivation Index, or ADI, to look at zip codes. And this is really a mammoth task led by one of our key researchers here, Dr. Amy Kind. They cataloged 69 million 9-digit zip codes. And if you look at the link there, all of us can access it, myself and you all as well. And those are the funding grants that provided that support. So I thought it would be good for us to look at your state, and then we'll look at my state. And so when you look at the state of Connecticut, the way the color coding scheme works is that the red, light orange, these are the most disadvantaged areas, where the darker blue are the least disadvantaged areas. And so as we see here, maybe in the southern tip of your state, we see they're less disadvantaged, whereas other aspects, and you guys know your state better than I do, so it'll be interesting to hear your thoughts when we have time for talking after the talk. So as we drill down into kind of looking at the major cities and areas there, surrounding states, and we look at the Yale New Haven health system, at least the hospitals that you guys have listed that I could put arrows at. We look at Greenwich, which apparently looks to me like it's a pretty healthy neighborhood, less disadvantaged, very different than Bridgeport, New Haven, and then near here, near New London, where Lawrence Memorial is located. If we drill down into New Haven, we see that the density of more disadvantaged neighborhoods is pretty telling, with a few pockets where they're the opposite. So how do we look here in Wisconsin? And when we look at our similar pictogram, so to speak, we're a very different state. So we've got a lot of rural areas that are here up north that are disadvantaged. Over here is Milwaukee. As we zoom in, you'll see some of the disadvantagedness. I'm located here in Madison, surrounded by blue. There'll be a pocket here I can explain and show that to you as we kind of, and then our more western on the border of Iowa, we've got some rural disadvantaged areas as well. So here's Madison, a lot of our suburbs here, Middleton's where I live, Fitchburg, etc., all not very disadvantaged. This pocket here is South Madison, which is a predominantly a community of color, of African Americans, and is more disadvantaged. When we look at Milwaukee, one of our more major metro centers, we see telling story that the suburbs are non-disadvantaged, whereas Milwaukee is heavily. And then with the Jacob Blake incident, that was kind of south of the city in Kenosha. So when we talk about kind of the impact of these different factors, socioeconomic factors, and how it impacts on our health, and in this slide, it's mortality on the Titanic. this is nothing new. This was from 1968. And what you saw here, whether you looked at women or children, and you always think of when there's a disaster, everyone yells out, or at least in the movies, get the women and children out first. And what you can see is they should have said, get the women and children with first class passenger status out first. And that's exactly what they did. And so you can see here that kind of classism still was alive and well back in the 60s as it is in 2020. So why is there this great divide between these two Americas? And I think we have to go back to the beginning when we read the Constitution. And it says, we the people of the United States, in order to form a more perfect union, establish justice, ensure domestic tranquility, provide for the common defense, promote the general welfare, and secure the blessings of liberty to ourselves and our posterity, do ordain and establish this Constitution for the United States of America. What an amazing document, and what amazing words, and how it's guided and continues to guide this country. But I think it's really important, and what you'll see as a central theme, which we have continually struggled with in this country, is who is the we and we the people? Is it you? Is it me? Is it all of us? Is it just some of us? And again, this John F. Kennedy, ideas have endurance without death. So to critique this wonderful document, which seems very hard to do, or because it is a great document that I hold in high respect, these brilliant, it is brilliant yet contradicting. The absence of not banning slavery in the Constitution was one of the great paradoxes of our founding era. The framers were revolutionary thinkers. Their ideas of fairness, justice, individual rights are what many world leaders emulate today. Countries want to grow up and be the United States. Why then did so many brilliant minds pledge to champion the rights of individuals, but on one hand, treat other individuals, human beings, as though they were just livestock? And, you know, it's not a hard thing to think that profit and money and all those things come into play. And racism indeed was profitable for this country. So a few slides of our past. These are not our best days. We see here some of our African-American citizens, Black citizens, equal rights for all. We see that women fought for the right to vote. It wasn't given to them. They had to fight, to get it. And that success, and kudos to them. Give us American rights. Go home, Negro. I didn't come here on my own. It's a lot, and yet the pride, and I think in this modern day, people try to say that individuals don't have a pride in this country. I think we do, and it's not that, I mean, there are points that we do disagree on, of course, but we actually really want what the Constitution has really articulated. We want to be in the we. And we see other things from Japanese internment camps. This is a white man's neighborhood. We see our LGBTQ community undergoing vandalism, as shown on this picture here in Richmond, Virginia in 2017. And in 2016 here in Madison, these homes were in the university bookstore, a swastika, an F-bomb, and affecting our friends who were from Jewish backgrounds. And then, not too uncommon, here we see this elegantly dressed Black woman, and we see these armed, militarized police. And I find it interesting that our 34th president, Dwight D. Eisenhower, said, "Together we must learn how to compose difference, not with arms, but with intellect and decent purpose." And to me, I kind of see on this side of the equation really maybe one person who seems to embody that quote rather than the others. So the term systemic racism is brought up a lot lately. If it's as often at your institution as is ours, I thought I'd share some quotes, because again, does it exist? And not everyone agrees that it does. So here are some quotes from those who don't agree, and one who does. I think some of the rhetoric, says Senator Ted Cruz, that has been used in the wake of Mr. Floyd's killing has been inaccurate and harmful. A great many of my colleagues use the phrase systemic racism to suggest that the entire criminal justice system is imbued with racism. I don't believe that's accurate. And I would agree that the entire system is not flawed. I mean, we've learned from taking our tests that you never choose always and never. So that's kind of but that's his view. Republican or Representative Scott Perry, who's a Republican in Pennsylvania, said, what is systemic racism? That means there's a system of, if there's a system, someone had to create that system. Perry said at a local Rotary Club event, someone is operating and nurturing the system to keep it going. I don't know who in our country is doing that. And then Senator Harris, at the time, accused Trump of a pattern of racism, citing his ban on several Muslim majority nations, labeling Mexicans rapists and criminals during his campaign, on and on and on. And when I kind of want to go back, I want to pull out Representative Scott Perry's comment, and also tie that in with a really good book that you should read, or if you haven't, called Caste, which talks about kind of systems that are invisible, and it uses the link between America, India, and then Germany. And I want to just say invisible systems, and use the analogy of the invisible dog fence. And the dog knows it exists. Does this apply to the systemic racism question? And so I think if you've lived your life and you've never really been affected by racism or any isms, you may go through life just not really being able to see that as a tangible kind of statement, because you really are, you're immune to it almost. And so I can see how a statement would come about. But again, I think at least in the field of medicine, being reflective and being open to different perspectives is really a cornerstone of our education. So I want to talk a little bit about how do we bridge this great divide, and what are some modern day responses. This is what we've done and I've seen around the country: anti-racism initiatives and statements, allyship in the workplace, bystander training. How do you handle microaggressions that may go to one of your trainees or one of your colleagues? Really being focused on what we, and I want to apologize, I didn't recognize Dr. Harris Foster, who's coming to mind right now. Sorry, Dr. Foster, I apologize, as he's been instrumental in my career. And I remember when we interviewed at Yale, and thank you for your investment in me. We look at the 1619 Project from New York Times, kind of really putting into print and archiving the challenges of specific ethnic groups in this country. And then different cities and states. Here in Madison, our city has said that racism is a public health crisis. And the American Academy of Pediatrics addresses racism and its impact on children and teens, and they actually have a detailed statement. What I want to kind of help you, and it's helped me when I think about systemic racism, is think about things like as being systems and systemic challenges. And one way to address or think about systemic racism is more gaining a better structural competency, which one of my friends and colleagues, Dr. Jennifer Edgoose, has articulated in our family medicine department. In order to do so, we have to understand the historical, cultural, political, and economic factors that have really shaped bias in us personally and also in our institutions, and how these actually impact disparities at all levels, not only economic disparities, but for us, health disparities. And I think a fundamental question goes back to the we, the people, and really who's the we and really who belongs. Because if you belong, then you get full opportunity for all the privileges and all the things that America aspires to be. And I think for us, we really have to look outside of medicine. And this is an institute at UC Berkeley. It's called the Othering and Belonging Institute. And this is Professor John Powell. And I would kind of give the analogy that an institute like this is actually like a cancer center where it brings multiple disciplines together, policymakers, stakeholders, communicators, researchers, to look at ways to build, to eliminate the barriers for us being a more inclusive society. So before we dive too deep to lighten it up a little bit, in the Midwest and definitely in Green Bay and Wisconsin, we love our Packers, and the Packers and Bears rivalry is really deep. So, you know, we've got, you know, here's this Bears fan going to the bathroom, what are you doing? And then we've got even the family split where mom on game day is outnumbered by her boys and husband. But as we really think about what othering is, it's not those cartoons. It's really a set of processes that the goal is to marginalize individuals, to marginalize communities, and to really highlight our differences to keep us apart rather than bringing us together. And you can see the different ways that that is done. This is my only political slide that I show, and I don't usually do that, but I think it's really important. And so this is from Statistica, which is a link that does a lot of statistical analysis. And this could apply for anyone, but this is President Trump's. And this is where narrative matters. So this actually catalogs from 2017 to 19, how many times he's talked about our very valuable immigrants in this country who've made a significant contributions. And we are great because of that spirit, of which the Statue of Liberty actually embodies that spirit. But he's used the term alien 213 times, criminal 189 times, the hell out of our country 43 times, animal 34 times, killer 32, predator 31, invasion, invade 19. So the narrative matters. So when you keep talking about individual groups in this way, I want you to know that whether we're all exposed to this, whether we're, you know, in one, you know, kind of belief pattern or another, we're all exposed. And this trickles down to what we hear in our news, what we talk about, what we see, et cetera, et cetera. So the narrative really matters. So I want to talk about othering and kind of break it down in terms of the mechanisms of othering. First at the individual level, and also known as implicit bias, and then at the organizational level or structural processes that I think at first it's hard for us as individuals to think about how we function in structures. It just is weird, but I'm going to do my best to help you see that. So when we think about our conscious and our subconscious, and we use the analogy of our brain being a supercomputer, it's processing 11 million bytes of information per second. And so consciously, we're only aware of 40 of these bytes. And behind the scenes, our subconscious is just churning and churning. And it's doing sorting, it's making associations, it's filling in gaps, all at the speed of light, literally. And that can lead to certain biases across different groups and things of that nature. And I'm going to show you a couple. So this was a controversy that happened in 2013 at the All-Star game in baseball. And this singer, they said, "You're not an American citizen, therefore you should not have performed God Bless America song." Does he look American? I don't know. You tell me. Yes, no. Well, actually, indeed, Mark Anthony is a proud American of Puerto Rican descent. And when Puerto Rico had its challenges with hurricanes, many of us forgot that Puerto Rico was actually a part of the United States, and it is, and a valued part of it. We didn't forget it when we ran out of IV fluids, did we? So to emphasize his point about Americanness, Mark Anthony reminded us that the song that he performed was actually written by a Russian Jewish immigrant, Irvin Berlin. And so this situation is really emblematic of the ignorance that often accompanies bigotry, but more importantly, it leads us into the critical conversation about who qualifies as a member of the American family. Again, who is a true citizen, who belongs, who's we the people. This is one of my favorite pictures. I remember watching this live, or at least probably delayed live on the, because it was in Brazil. But 2016 Rio Olympic Games, and Simone Manuel actually was the first African-American gold medalist in swimming. And this is to highlight that role modeling matters. So here's this little African-American girl with her stars and stripes on, smiling. And you can only imagine what's going on in her mind from, I can see myself in her. Hey, mommy, hey, daddy, she looks like me. Maybe she didn't like swimming. Maybe she decides to tackle swimming now because she sees someone who she thinks represents her. Now, this also shows kind of that unconscious bias. So in a newspaper article published by the San Jose Mercury News, which is right down the street from where Simone Manuel was a student at Stanford, had the headline, "Phelps Shares Historic Night with African American." And you can see how this is it's wrong, right? So a historic night where you have the first African-American swimmer and that person's name isn't even mentioned, not only on top of that, but she's woman. And now there's all sorts of amazing accomplishments and she's just labeled as African-American. And they knew her and they knew her by name. That's how the unconscious level, it just clicks at a level. So we really have to be mindful and really kind of dig in deeply to think and be reflective. So let's look at things from the organizational or structural platform. And really othering in this sense is intended to create separation, not to build connectedness. When we think about outcomes and understanding ourselves within structures, there are all these things that come into play. Our cultural structures, their physical structures. So where you practice, you probably think about different resources you have at any of the number of Yale New Haven health sites you may visit or practice at. What are social structures that are around, or cultural belief systems? You may approach things differently when you talk to a patient from a certain age or certain background. And all these contribute to the eventual outcomes that we hope are positive and good outcomes. So what are some examples of structural othering systems in our country? There are laws that define whiteness early in this country. Originally, when Irish individuals and Italian individuals came to this country, they were not white. They were later considered white by law. That was actually a policy that was written. There were segregation and Jim Crow laws. There was in South Africa apartheid, and kind of jumped out at me in preparing this talk that really apartheid is apart, separation, A-P-A-R-T. And there's policies and systems of segregation or discrimination that have been based on race and other things. And really, when I step back and look at the Black Lives Matter comment, and I don't know all of the details of what they stand for, I think to me it's them saying, we belong, we the people. It's a counter response to this separation and non-connectedness. It's not saying our lives are more important than anyone else's lives. It's really saying if you pick the lowest denominator of lives in this country, and sorry to admit that, but at least that's how it plays out thus far, up to 2020, then if that life matters, then we assume that everything else above that life matters. That's how I view what Black Lives Matter is trying to say, straight and simple. So let's look at areas that we're probably a little bit more comfortable and familiar with in terms of how do these systems or structures or invisible barriers kind of set up othering, either at the college or higher education level, in academic medical centers or major healthcare systems. This is some data from Sarah McLafferty at University of Illinois Urbana-Champaign, where she looked at kind of GPS or GIS kind of analysis. And one thing that I really want to stress about place, space, and health, and I'm going to say it a couple times, place, space, and health, is that people create places and places create people. And that's really important, right? So you guys are an amazing department because you have amazing people. And those people have created your place or your department. And now that department, that culture of that department continues to create and facilitate you being great people and attracting other great people into your environment. So it's really important concept. So this is looking at structural racism from a GPS perspective. And this is actually Chicago. So I love this slide because it shows you that there was intentionality in how Chicago was set up. If we looked at what would the Black population here in the darkest blue color be, where would they live in Chicago if it just happened by random spatial distribution? We know that from our research backgrounds and our reviewing statistics and randomness, this is what Chicago would look like. You'd have a density of African Americans or Black people here and here and here. They'd be kind of sparsely throughout. This is actually what Chicago looks like. This is the South Side. And so very intentional to put me, into one place in one location, low resource. And again, going back to place, space, and health, and how people create places and places create people. And what about if we get out of race and let's look at geographic disparities in cancer, breast cancer. So I won't bring it home to urology yet, but I will. And so if we looked at, again, the dark blue are the areas where you have late stage breast cancer, and it's kind of populated, a little bit more density here. But what about when we look at mammography facilities in the state? They are all densely over here in an area that has very little late stage breast cancer. Is that a surprise? How about that? If we pick up the disease earlier, maybe we won't have a lot of late stage breast cancer. But definitely you can see when people were thinking about where to kind of strategize to put these facilities, again, you have to step back and think about where are the populations, where are people potentially under-resourced, and make sure that you may actually need to slant the distribution in an under-resourced area. Just like when you're taking care of a patient who's more complex, you may need to do something a little different than your normal routine of how you perform your surgeries or take care of that person in the clinic. And I think this underscores. So the author's conclusion from this study was access to healthcare resources for cancer screening and treatment is geographically and socially uneven. So what about, you know, kind of our area? And I'll kind of just use prostate cancer as an example and give courtesy to these slides from Dr. Samuel Washington III, who shared these with me when he was a fellow. He's now an assistant professor at UCSF. And so this was data by Ed Schaefer and his group at Northwestern. This was the effect of socioeconomic status, race, and insurance type on metastatic prostate cancer. Their hypothesis was lower socioeconomic status is independently associated with the higher odds of metastatic prostate cancer at the time of prostate cancer diagnosis, regardless of race or regardless of insurance status. So just basically SES is the driver. And Dr. Hittleman from his days in capture from UCSF, this stuff is very, very, very familiar. It's the same story. And so when we look at things about among all races, lower socioeconomic status was associated with a higher rate of metastatic prostate cancer and was clinically significant. When we look at white individuals, we see things marched up here from having a better socioeconomic status to a worse. And then we see the same things with Black individuals and Hispanic. What we see, however, is that they are still worse in our patients of color compared to individuals of white backgrounds. And when we look at insurance status, we see that insurance does indeed matter. And we're aware of that in terms of access to care, utilization of care. But we see that it impacts our patients and populations of color more so up here. And we see that private or Medicare patients did better than those with Medicaid or no insurance. And I think these were some of the takes, and this is really Dr. Washington's work. So what did the authors say? Decreasing socioeconomic status, race, and having Medicaid or no insurance affected a person's higher likelihood of having metastatic prostate cancer. the critique that Dr. Washington raised to all of us was that, can we really present socioeconomic status, race, and insurance as truly independent factors? And the answer is usually no. And this goes back to when I was a fellow at UCSF and capture education, race, income, they're just all linked together. It's hard to untangle those. So an important question that Dr. Washington raises is race as a social construct, a fundamental cause of disparity, and what aren't we really addressing in the literature, right? Because this isn't, I mean, this is a good paper, right? This was 1 million men, this is a huge paper, but if this is information we haven't heard before, then I'd be shocked. Maybe it's your first day on urology and you can say that, but for most of us, it's kind of the same drumbeat of race, and poorer outcomes. So Dr. Martin Luther King Jr. Back in 1966 said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And I think those are examples that as we think about ourselves as large major academic health centers, as departments, as higher education, we have to step back and kind of take off at times our business hat, our enterprise hat, and kind of think in a different perspective in terms of where are we putting distributing things, and how are we kind of doing equity, which is not equality. They're different, to kind of even the playing field, so to speak. So how do we bring this all together, or how do we bridge this divide? And that's really what I think is really creating a culture of inclusion. And I'm going to focus on what can you do in your workplace, in your department, in my department, in your section, in my section. How do we bring all these pieces of the puzzle together? And I want to look at it from 2 levels, institutional and individual. So again, these are kind of the modern strategies that probably at Yale, they're doing the same. You know, actually I did. I saw your diversity statement because I had to come out with a response as well. Diversity statements, anti-Black racism statements, inclusive excellence, centralized and coordinated diversity, equity, inclusion efforts across the scale of your enterprise, communicating institutional core values. What do we stand for? The AUA has kind of come out and gave what they stood for when a congressperson had a statement that went against AUA core values. Workshops and training on bias and privilege and social justice. And for our students here, we have mistreatment reporting hotlines to let us know, have you been fairly untreated on your rotations or any way? Did someone use a microaggression or inflammatory statement in one of your lectures? How can we keep a track of the total N of when we aren't having our best days? And one strategy that I've seen instituted really well here in Madison in our community and family medicine department is they use the acronym TRUST. So T is for tracking. So are you tracking your efforts to diversify your department? How many from the resident level to the mid-level provider level to the faculty? What about recruiting? Are you being, is there an effort to recruit a more diverse faculty group across all levels, from gender to race to sexual orientation, sexual identity? And then I think what's really key, which really embodies, I think, a lot of us in medicine, and they actually said it, I remember early in my medical school years, our dean said a really grand statement. He said, I have some good news and some bad news to tell you. He said, the good news is that 50% of what we tell you is going to be true. And he said, the bad news is I don't know what 50%. And so that underscores to me that there's some things that we have to unlearn about our own biases and our own preferences. And there are things that we need to dig in and learn. And then we need to be committed to sustaining and retaining that new knowledge and that new kind of almost process of how we process things. And then be consistent in our training and being transformative. It's really been principles that have guided them. So what can you do at the individual level, right? Because, you know, someone just comes up to you and, right, it goes, systemic racism, you know, we need to get in the game. I'm like, it's like, here in Madison, Ironman and triathlons are a big thing. Someone came up to me and said, Ironman, you need to get in the game. And I'm like, holy crap. Like that's, swim 2.4 miles, bike 112 miles, run a marathon. Okay. And you might be saying, I haven't run a mile in like 7 years or something. How do you get in the game? Just like in systemic racism, educate ourselves, or good books or good podcasts. Learn to celebrate the differences across ourselves. Listen to others. I've really learned that a lot of our key leaders actually are really good listeners. That's actually a skill I can get a lot better at. Improve your communication skills. So one area I used to always do, and I've learned from my friends who come from Asian backgrounds, is sometimes say, where are you from? Or let's say you have your lone minority student on your rotation and you really are interested in that person. You go, where are you from? There's a dual message there. That where are you from is like, where are you from? Like, I'm from Madison, Wisconsin. How about you? Or is it like, where are you from? Where are you from? Oh, I'm from Uganda, or I'm from China. And so a lot of my friends who are Asian have kind of felt that that question is actually like, really, is there a hidden, are you an American citizen question? So I've changed the way I communicate that. And I go, instead of saying, where are you from? I say, where do you consider your hometown? And leave it at that. Or where did you grow up? And I'm really curious and interested. It's not an empty question. I really am interested in that person. And when I have new medical students in our rotation, I want them to feel welcome. So that's a way to be intentional. And then to really expand your circle of human concern and really see people. It's an easy thing to see, but see them. Don't just notice them. Value their humanity. So that's like, right, we've all been in meetings where you're at the table and people look at you like you're not at the table, like you're invisible. And that's even worse than not being at the table. If I'm an invisible person at the table, just let me leave the table. It's not helping me. It's not helping you. It's not helping the group. So we really need to harness in being inclusive and an inclusive mindset. So these are ways we can all, and I'm first on the list, expand my circle of human concern. Don't deny someone's humanity. And I think that goes back to that slide I showed about the things about immigrants. If I'm denying someone's humanity, if I'm not going to deny it, I wouldn't call that person, you alien, hey alien, let's go grab some lunch. Let's get some coffee at Panera. I wouldn't call them, hey criminal, let's do it, right? That's demeaning someone's humanness on all of these levels that are listed. So so why is this like resonate with me and probably with you all in the field of medicine? Well, because you took a pledge. When you were a first year medical student, nowadays they do the modern Hippocratic Oath, and it is incredibly a diversity statement. I will not permit considerations of age, disease, or disability, of creed, of ethnic origin, of gender, of nationality, political affiliation, of race, of sexual orientation, of social standing, or any other factor to intervene between my duty and my patient. I will maintain the utmost respect for human life. So we were born for this. We should be the leaders in this. It's what we embody. It on the back of your ID. This is who you are and who we aspire to be on a daily basis. Do we miss it some days? You betcha. Do I miss it some days? You betcha. But it's something I hope that I can embody and is really human. If we value each other as human beings, I think a lot of these other things between othering kind of falls off. So I want to kind of end the slide by focusing on the value of mentorship, and I really want to focus on the value of mentorship in terms of gender. This is a report that came out recently about women in the workplace, and you can actually look into this, and it is indeed kind of a crisis, and this isn't just in medicine, it's across all areas. So this is how quickly women are leaving STEM fields. 22% are leaving at 3 years. At 12 years, 50% are leaving, and then it's 20 years, 60%. And this slide really talks about the gap in the talent management that we're mismanaging as we're seeing men kind of climb up from entry level, let's just call this assistant professor, to being a chair, to being in the C-suite or a dean, or a president of a health system. And we see that men are, they're climbing. Here we go, guys. We're getting there. We're getting there. We're getting there. And our women are saying, enough is enough. We're not valued. We're getting the cruddy jobs. It's not going to, be transformative to my career. And this is all the talent that we're losing. So how do we make a difference? And this is an article back in 2017, and it's how women mentors make a difference in engineering. And I love the term, and it really registers in what we're in currently. And it said, this is what they quoted at the time: female mentors act as a social vaccine that protects female students against negative stereotypes and gives them a sense of belonging. And as we go further into this article, for some women, enrolling in an engineering course is like running a psychological gauntlet, from sexual harassment to sexual jokes. It's no wonder that only 13 to 22% of the doctorates in engineering are held by women. Female engineering undergrads who are paired with a female mentor actually feel more motivated, more self-assured, and less anxious because they're affirmed. And it's not that having a female mentor increases their confidence, it just preserved it until they could kind of get their own strength and their own confidence. And I think hopefully we're seeing that in our departments and our divisions as we're starting to increase the gender diversity in urology. Think about those trailblazing women who are the only woman amongst all the residents and had to deal with those different stereotypes and feeling as though they belonged or didn't belong. And so I do see positive steps being made in our field as well. So this is just to show you some of the impact that we're making here in Madison. So if you look at our chairs of departments, the red color is women chairs nationally, represent about 25%, 75 are men. Here in Madison, over 50% of our chairs are women. And that's because we've been very intentional and very lucky to recruit these great leaders who just happen to be women. But we have a long ways to go regarding race. As we see the victories here from the number of women increasing who are graduating from medical school from back to 1980 to now being on par with the number of men graduating from medical school that are decreasing. We see for men and women of color, Latino, Latinx, or Black, or African American, those numbers haven't budged in over 32 years. So the last thing I really want to kind of give you ways to, kind of envision this in your own department is really considering diversity, equity, and inclusion work alongside your well-being work. And to focus, and this is how they do, this is what they approach in medicine, the Department of Medicine at University of Michigan, is they talk about developing their people. Let's improve the environment, that's culture. Let's build partnerships, not only within our department, but across different departments, but also community partnerships. So when you saw the different disadvantaged areas that you guys have, kind of are practicing in, are those partnerships there? Do they need to be adjusted, or do they need to be established and continued? And then communicate your results when you have progress, because oftentimes what happens is we wait until there's a horrible incident usually on our college campuses that deals with microaggressions, and then that gets out. Now we're always apologizing, but we're not showing hopefully the good work that we're trying to do on a daily basis. So I'll end with this slide by Peter Drucker, the father of management theory. And what he says is, unless commitment is made, there are only promises and hopes, but no plans. So hopefully this talk is a different talk, and it gives you some information to help you along your diversity, equity, and inclusion path, as well as the department, and for all of us to dig in and make commitments that make things better in our spheres of influence, but also beyond those spheres, out and beyond the four walls of our work, but out into our society as well. So thank you very much. I appreciate the opportunity to be with you all this morning.
Dr. Downs, that was fantastic. Thank you so much for being here. I think we have a few minutes for questions or discussion.
I have a question. That as always was fantastic. I always enjoy hearing you speak. So I've been learning from you for a long time now. One thing you've talked about in the past, and I just want to kind of a little more on a micro level for us specifically in other programs, you talked about virtual mentoring and helping programs maybe with some less diversity find opportunities to reach out. Could you just make a comment about that? Because I always thought that was a great idea.
Oh, thanks, Dr. Hillman. Yeah, I think what we're really poised, I think now, and hopefully at this year's Society Academic Urology, of which Dr. Hillman was the past chair of the diversity task force, is we're going to bring in different groups and how they do mentoring, from UCSF, which has their ureter program, to see how the Colorado, their model, Michigan, and then within R. Frank Jones, which is the Black Urology Society, one of our members has created a nonprofit called Unbound Urology Unbound. And I think we'll be set up to do that. Here in Wisconsin, we actually have a program for our first year medical students called Building Equitable Access to Mentorship. We call it BEAM. And really what we've done is we've partnered with experts in mentoring. We have a curriculum that is actually CME and is that you can access virtually, just like we are today, and kind of to train people officially to be really good mentors. And so I agree 100%. What we need to do is kind of harness that power. So if you're out in wherever in the country and you've got two, diverse candidates and it's hard for you, let's all pool our resources together and lift everyone up, as well as our specialty.
TD, great talk as always. Thank you for helping inform us about a lot of these things. We had a talk by Dean Lattimore here not many months ago, and I made a similar comment to him that these things that we do are important and they're great, and I know that some people change and they're KKK members who are now the most ardent civil rights advocates that exist. I realize that does happen, but I feel like a lot of people at a certain age, it's hard to change. And I feel like kids are not born with a feeling of, I'm better or I'm worse than somebody else. I feel like that's a learned thing, and learned through all the systemic things that you just talked about, which are really important to understand and help change. I feel like if some, and I don't know how to do it, I don't have a solution, but I feel like the intervention at the kid level, however that is, whether it's more teachers of color, if it's more teaching of civil rights problems and earlier in age, I don't know. I'm just throwing things out there. But I think if we really want to change society, 50, 100 years from now, or not even 100, but just 30, 40 years from now, I feel like that's where the biggest changes could be made.
Yeah, I couldn't agree more, Dr. Singh. It's interesting, and on a lot of levels, and I'll try to see if I can kind of condense my comments, is I am inspired by the age, and that can change in the sense that I'm a Black urologist in a predominantly white state. So I probably now, we're at a whopping probably 3 Black urologists in the state of Wisconsin, one of which I've trained. And when but the role is different. So when, say, the upper northern Wisconsin, say, white woman comes because she has bladder cancer and I treat her, we connect and we bond. And but the question is, does she see me as like, Black male who she sees on the street, or who is in the grocery store or wherever else? But my role in some ways is a little transcendent, which is good and bad. But I think through those interactions, there's a chance for even the older group, I think, to start to kind of unlearn. For the younger group, I agree. And I really hope that does change. What's scary is, there was some of these experiments that were done on school-age kids, all white kids, where they used the blue eye, brown eye experiment. And they had one group, they said, all you blue eye kids, you guys can have lunch early, you can have twice the recess, and you get all the privilege. And then the brown eye kids, you can't do anything. And literally it took maybe about half an hour before the kids in the privilege group started to identify the brown eyed kids as bad, as lowly, and then they reversed the experiment and it returned the same way. So there's probably a window in having raising 2 Black kids. I'm very aware and think about when do they start to recognize their colors different. And they do probably around, probably somewhere 4 to 6 years old. But their friendships are real. And so the way we can help as parents and as community members is if we find that we're in all white spaces or all one spaces, that could be all Black spaces, all Indian spaces, and there's not other, then we're just facilitating that conversation and uncomfortableness for our kids. So we've got to make time to interact and ask, why isn't our we're having we can't do group dinners or anything like that now, right? But why isn't there more diversity? And I think when the diversity statements came out and everybody was kind of wanting to say this is horrible what's happened regarding these violent killings, it was everyone was reaching out, and on the tongue-in-cheek part of me is like, wow, that's because you got one Black friend, and like I'm that person for 20 of you, and that's good and bad. I thanks for your friendship, and you consider me a friend. But it's also kind of a sad thing too that you don't have a more diverse group of individuals. So that's, but it's a really good point. We got to fix it, Dr. Singh. Otherwise, and we also have to be humble to think that there are other generations that had the same, hopefully, mindset and they failed. So what makes us special? And I sure hope that we are. Otherwise, we'll be the same failed experiment yet again, and that'll be miserable.
Well, Dr. Downs, again, thank you so much for joining us this morning. I know that I think we could continue this conversation, and I would love to continue this conversation. But unfortunately this morning, I know that everyone has to get on to the OR. But thank you again for joining us. It was phenomenally insightful, and we would love to continue the conversation again in the future.
Oh, thanks, Dr. Kinney. Thanks so much for inviting me. And I know that Dr. Singh had reached out to me initially, and thank you to Yale Urology for this opportunity, and wishing you all the best, and definitely to be safe and healthy for yourselves and for your families and your friends and your loved ones. Thank you.
Thank you very much.
Okay.
Be safe. Bye-bye.
Great seeing you. Thank you so much.
Thank you.
Thank you. Thanks, you.